Lou Irving's been a respiratory physician, and he's been our chair of the immunisation influenza specialist group and has been chair of this meeting forever. But he's going to actually give us a talk based on his work as a respiratory physician and a lot of experience in Melbourne. And thank you very much. Talking about clinical management, because it's not just one disease, it's hundreds of diseases. So thanks, Lou.
Rod, thank you. And I've got more questions than answers, unfortunately. This is quite a tricky area for a clinician. And I want to specifically focus on, the lung can be co-infected in many ways with different pathologies, but I want to focus on that bottom situation, an acute illness where one or more viruses is involved, or a virus and a bacteria is involved, because I think that's probably numerically, in terms of general practice and hospital medicine, the most common scenario. And in showing some data, you need to keep in mind that there's a difference between the upper respiratory tract and the lower respiratory tract. And there's a difference between bronchitis and pneumonia, and I'm going to focus mainly on pneumonia. What we've known for a long time that the upper airway is colonised with organisms, but in the last 20 years, we now know that there's actually a microbiome in the lower respiratory tract, and some of what I'm showing you will reflect that. You need to keep in mind where samples have been taken from. It's very easy to get a nasopharyngeal swab, but that may not reflect what's actually happening at an alveolar level. You need to keep in mind the sensitivity of some of the tests I'm showing you, because they're highly sensitive, and the timing of those tests, and possibly the changing epidemiology. So to set the scene, I just want to show two quick cases. This man was admitted to our ICU last month with septic shock. He had 1 day history of fever, breathlessness and a cough. On admission, a nasopharyngeal swab was positive for flu B and for rhinovirus. Sputum, blood, urinary antigens were negative for pneumococcus, atypicals, etc. A chest x-ray showed a right lower lobe pneumonia, and a CTPA showed very extensive consolidation in the right lower lobe. He was previously well, but interestingly described an acute 3-day flu-like illness 10 days before, which spontaneously resolved. He was treated with broad-spectrum antibiotics, oseltamivir, oxygen, noradrenaline, and had a full recovery, although it took time. And the question is, what caused that acute illness? And in the past, I would have said that he probably had influenza 10 days ago, and he presented with pneumococcus, and we only find the bacteria in about 50% of cases. But was the preceding illness rhinovirus, and was the acute influenza? Could have we withheld antibiotics? So the second case is still in hospital, a 50-year-old woman who migrated to Australia 30 years ago. She's got non-pulmonary sarcoidosis and is being treated with infliximab, which is a TNF blocker. She presents with a 5-day illness. A trial of antibiotics didn't improve. She then had a chest x-ray that showed patchy consolidates, and she was admitted, and a CT in fact showed widespread patchy infiltrates, not only in the right upper, middle and lower lobes, but also in the left lower lobe. At admission, she was flu A positive, and her sputum showed an MRSA. She subsequently had a bronchoscopy to exclude TB and other pathogens, which were negative. So, what's causing all this? What's the culprit? And are infiltrates actually pure infective? Are they related to the infliximab? So, acute respiratory co-infection is increasingly reported in the last 20 odd years, and partly because we've got more sensitive tests, partly because we're actually looking, and partly, as Ian pointed out last night and Alan, that in the old days, if you had one virus, you couldn't have another virus. But that belief has changed. And there's a variable definition of co-infection, but in general it means organisms from the same sample or within 2 days of the sample being taken. And it's recognised that it's having multiple pathogens, often but not always, has a worse outcome. So one of the first studies looking at virus-virus co-infection was this one by Esper and his group at the time of the H1N1 epidemic in 2009, and they looked at all their PCR positive swabs and ones that were PCR negative for H1N1 and looked for co-infection, and they found it in 13% of the H1N1 cases, especially rhinovirus and coronavirus, and they had a clinical severity score, and it turned out that cases where there was rhinovirus co-infection were actually less severe clinically than influenza by itself, and cases where there was co-infection with a coronavirus or other virus were more severe. This is a much more recent study from Ontario where again they look at their viral positive tests, and the samples can be nasopharyngeal swab, sputum and lavage across a wide range of patients. So some of them are from the clinic, some of them are from ED, some of them are hospitalised. And they found that 50% of the flu A, B and RSV patients were in hospital, and they were co-infected with bacteria in about 4 to 5% of cases at the time of presentation. Much less common in the COVID patients, although the COVID patients were actually a less unwell group. In contrast, secondary infection occurring a few days after presentation, was more common in the COVID patients who were admitted. So again, I think that's probably a pattern that we recognise. And again, this concept of looking at COVID positive patients and do they get co-infected has been studied a number of times. It was often triggered by the memory of what happened following the large influenza pandemics, where much of the morbidity and mortality related to secondary bacterial infection. But the bottom line is that at the time of presentation, co-infection with bacteria in COVID positive patients is uncommon, but very sick COVID patients who get admitted to, particularly to ICU, tend to actually then develop secondary bacterial infection. Part of that reason might relate to the heavy use of antibiotics at the time of presentation, and that could be one of the points for discussion. And again, this is making the same point that co-infection with COVID at the time of presentation is uncommon, but does occur in sick COVID patients if they end up in ICU. Just to remind you that there's very strong animal data that infection with influenza affects both affects immune responses, immune protection to subsequent bacteria. And we know that after influenza, a person is prone to a secondary bacterial infection for the next 3 or 4 months. Similarly, people who are colonised with bacteria, and these are mainly people with chronic lung disease, COPD, cystic fibrosis, have altered immune responses to viruses. So there's an interaction between preceding viral infection and preceding bacterial colonisation. To make sort of clinical management more difficult, particularly of these sick people, the CT findings of acute infection are not as specific as we used to think they were. So we used to think that a unilateral lobar pneumonia, for example, in that first case I presented, was going to be bacterial, but in fact the data shows that that's not necessarily the case, and that viruses can actually cause lobar pneumonia. And similarly, a bacterial pneumonia can be a patchy ground glass scattered infiltrate type pattern. So we can't rely on the radiological pattern to help us decide. So getting back to this man, hands up who thinks he was probably influenza followed by an undiagnosed, undetected pneumococcus or maybe mycoplasma. And that's certainly the way I would have approached it. But there are other possibilities. So this group prospectively tried to determine whether or not in a viral positive patient presenting acutely, whether you could actually not give the antibiotics. Now, remember that the logistics here are that, including in Australia, we now get the PCR result as soon as they're in ED. You won't get the bacterial stuff for a few days. So they're asking, this is a Canadian group, but they're asking the question, could you actually not give antibiotics in someone presenting with severe community-acquired pneumonia if the viral PCR was positive? And they recognise that it depends very much on where you sample. So it's a prospective study, but they only included cases where they got a good quality sputum sample at presentation, and they did quantitative analysis on the sputum, and they had a cut-off of greater than 10 to the 5 CFUs for the known bacteria. And interestingly, they included what we would normally call upper airway commensal bacteria, anaerobes, as potentially pathogenic if the concentration was greater than 10 to the 7 CFU. And I'm just watching Tony nod his head. I mean, it's clearly these organisms can be pathogenic. The person with bronchiectasis who's coughing up purulent sputum and has got a CRP of 150, and you get a lab result saying normal upper airway commensals, they're clearly not normal in that patient where they're dividing, which is in the lung rather than the upper airway. Anyway, that's what this group did, and so they classified 63% of the cases as being bacterial, and that included the commensals, 24% co-infection and 13% viral, and they looked at radiological features and biomarkers and clinical indices, and you can probably guess the outcome. But although the bacterial pneumonia was more likely in a subgroup of people, smokers and with chronic lung disease, although viral pneumonia was more likely if there was a preceding or concurrent sore throat, and although the bacterial viral were sicker, they couldn't find any reliable clinical or radiological or biomarker. They were using procalcitonin. We would normally use CRP. So the bottom line is virus, at least from this paper, virus-only community-acquired pneumonia could not be distinguished from bacterial community-acquired pneumonia, and hence the need for empiric treatment. So my summary, my conclusions, having read the literature recently and then thinking about the last 50 years of my career where there wasn't a microbiome in the lung, where you could only have one virus at a time, where bacterial pneumonia was always lobar and viral wasn't. My summary at the moment is that it's a mixed up, crazy area. Co-infections do occur. They probably increase severity. Determining at the time that you get the result or at the time that you want to treat which organism is important can be very difficult. Microbiological tests are very affected about what part of the respiratory system you actually sample. Radiological assessment just tells you that the patient's got an infiltrate, but it won't even tell you whether that infiltrate is a drug-induced pre-infection infiltrate or whether it's infective. I think it's highly likely, and I'll be interested in people's comments, that local epidemiology is really important, and having surveillance of what's happening in your community and that it's underused. We've got terrific tests for the microbes, but we don't understand what the microbes are actually doing to the lung tissue, to the airway epithelium. And so at the moment, it's full steam ahead with empiric treatment for sick patients, and all the more reason that we need to have very careful governance of not using antibiotics for people who aren't sick. Thank you.
Thank you. Had those questions online, but one's come up online is monoclonal antibodies, increased use in the sarcoid. Need a microphone over here. So because of the use of monoclonal antibodies, is that going to change your recommendations? Does that alter your thoughts about antibiotics? Although I'm relieved that all the Augmentin I've prescribed in the last week is appropriate because there wasn't any better choice.
I see this frequently at Peter Mac, where immunotherapy is used in almost every second patient, and the short answer is yes. So it alters the immune responses, but it also acts as a distractor. I still don't know whether that second case, whether the infiltrates are in fact steroid responsive, drug-induced inflammation, and she's really just got bronchitis and so time will tell. But at the moment, we don't have a real-time diagnostic way.
Michael Woodward. Lou, do we have any evidence in an immunocompetent person in the modern era with good respiratory support, do we have any evidence that antibiotics make a difference even if they're the correct one for a bacteria that's causing the infection?
So it's a provocative question, and Tony, do you want to answer that? I mean, do any of us have a competent immune system at the moment, post-COVID, and with all the air pollution? But anyway.
Well, we've got data for bacteremic pneumococcal pneumonia, Robert Austrian's paper from 1964, which shows pretty clearly in the pre-antibiotic era that 90% of people died, and in the penicillin era, 90% of people survived. What is correct, Michael, is that there is a small group of people who die, and antibiotics make no difference to the mortality at day 3. And those people are probably going to die anyway, whatever antibiotic you give them. And that's, you'd say, well, no, but we've got now modern ICU and support, but that finding's been repeated in the 2000s anyway. So there's still a group which we won't affect, but yes, antibiotics still do work, I think, Michael.
Yeah. Actually, but it's a really good point. And people who die might die of sepsis, but if you can't clear your secretions, you'll die. And that's why pneumonia is the old person's friend, in that very frail people, even if we sterilise the infection, if they can't clear the secretions, that they die of respiratory failure.
Just a question online is that does positive COVID alter your thoughts about what else you should be testing? So once you've got a COVID diagnosis, do you then ignore anything else?
Yeah, and I think, our next speaker will address this a little bit, I think, but particularly with COVID being less of a clinically severe, I'd be nervous about, in that first case, for example, if I knew that man was fully immunised, I'd be nervous about saying his illness was all COVID. I'd go looking for something else. Because these days COVID in that age group is a much less severe illness. Yeah.
Thank you. Thank you much, Lou.
Thank you.
Thank you.